30 to give his talk. We're going to continue on with this session, and the next speaker as well is going to be Dr. Kader Mate. He talked to us earlier this morning. He's from the Institute of Health Improvement, and he's going to talk to us about recent innovations for common hospital problems. Dr. Mate.
Thank you again to the organizers for inviting me to present once again on a second topic here. It's shortly after lunch. I'm sure everybody's a little bit tired, so I'm going to try to wake you all up just now with a very quick tour, if you will, through some important innovations that are happening in hospitals from around the world. We're going to start in Cincinnati. We're going to go quickly through Sweden, Pittsburgh, Salt Lake City, Singapore, a whirlwind tour, but I hope that some of these lessons and ideas will land on fertile soil here in Riyadh. So let's start here, just to begin with in this conversation. We're talking about shifting paradigms. We're moving from what healthcare used to be yesterday to where it's going to be tomorrow. And in between, there are a number of forces that are, in some senses, standing between where we are now and where we're trying to go. There's demographics, there's politics, there's history, epidemiology, obviously technology, and then a whole lot of other things all the way down to social systems and networks. Yesterday we had disease. Tomorrow we think we might have something different, something called health ease. Yesterday we had cures. Tomorrow we're looking for prevention and promotion. Yesterday we had physicians and nurses and they were divided. Tomorrow's era, which Dr. Zismer just mentioned, we might have multidisciplinary teams. In the past, we've had siloed specialties, especially. In the next wave, we're going to have integrated care. Yesterday, we've had hospitals. Tomorrow, we're going to have networks. And already here, I can tell that there are lots of integrated delivery systems and networks. Yesterday, we had episodic care. And tomorrow, we're looking for continuous care paradigms. In the previous model, patients went to providers to get services. In the future, the provider might be going out, and you just heard a conversation about rural care and how rural care is happening with providers actually reaching out into rural communities and in fact them going to the patients themselves. In yesterday's paradigm, the patient was patient with us as providers. In tomorrow's paradigm, we're finding that we're having patients that are actually impatient. They're proactive and reaching across to reach us. And in yesterday's paradigm, we focused on productivity. In today's and tomorrow's, we'll focus on quality, safety, and innovation. So let's begin. We're going to talk about some innovation categories, and when I was preparing this presentation, I asked Dr. Al-Tamimi for some ideas about what would be challenging here in Saudi Arabia, and he gave me a few different categories, and these are some of them. And we'll go through some of these just now. So let's start with improving safety. We're going to begin here, I mentioned, in Cincinnati. Every day for 22 minutes, an interprofessional team of nurses, doctors, administrators, clerks gather for exactly 22 minutes in the morning. Each department presents for 1 minute. Everything from parking and security to intensive care presents for exactly 1 minute on flow, how many people they think are coming in, how many people think they're going out, describing volumes, and describing possible safety events. Hospital leadership attends this, from the chief executive to the chief operating officer, and tries to solve problems that they anticipate through this process. Since the beginning of the safety briefings, the daily safety briefings, serious safety events have fallen by more than 60% across the system, and this in a matter of 3 years. Okay, next we're going to move to something called the IHI Global Trigger Tool. Again, the institute where I work has developed a number of tools to assist hospitals in improving safety. This is one of them. This is a simplified, innovative tool for sampling and quantitatively understanding the level of harm happening right now in your hospital, in your wards. This tool has been used all over the world, and it captures near misses and adverse events and serious safety events like the ones we just mentioned in Cincinnati. We have a saying at IHI, if you don't name the problem, you don't know what you're fixing. This is innovation in knowing and quantifying harm. And here's innovation in spread and change at a national level. This is safety throughout the system. Our chief executive, who I introduced to you in the earlier talk, challenged the US healthcare system in December 2004. He said that with this line, some is not a number and soon is not a time, he asked us how much by when. How many lives could we save if we implemented safety protocols and practices throughout American hospitals? He elevated safe care into a countrywide initiative. He had named a problem and that needed a solution. And this is how we did it. This is the campaign to save 100,000 lives, operated in 24 months. It enrolled more than 4,000 hospitals in the United States and their communities in this work. It sought to build a national infrastructure for change and transform it into a national asset for future change. And it raised the profile of hospital safety as a problem for the public. And it worked. Within 2 years, and there's some controversy about how these numbers were arrived at and how they were measured, but some estimates have suggested that the campaign saved 122,000 lives during the course of the 2 years. How did we get there? How did we get to this 100,000 lives? Well, we simplified things to the essentials of evidence-based care and used bundles and checklists, clinical reminders, tools that help clinicians remember and change behavior and to deliver care more reliably. We used 6 interventions: rapid response teams to respond to clinically deteriorating patients, evidence-based care for acute myocardial infarctions, medication reconciliation for prevention of adverse drug events, a bundle for central line infection prevention, a bundle for surgical site infection prevention, and a bundle for preventing ventilator-associated pneumonia. And this demonstrates the power of naming a problem. The campaign to save 100,000 lives has now been replicated in over a dozen countries, from Denmark to South Africa to Canada to Scotland, and back again in the United States, where we relaunched the campaign as the 5 Million Lives campaign and the Million Hearts campaign. Let's move on to reducing waste. Here, I'm going to start with this set of data. Earlier in this year, Andy Hackbarth and Don Berwick demonstrated or estimated the waste that was prevalent in American hospitals. Waste in failures of care delivery, failures of care coordination, over-treatment, administrative complexity, pricing failures, fraud and abuse cost our system, the American system, $911 billion, nearly $1 trillion in annual waste in the American healthcare system and its hospitals. So what do we do? How do we tackle this problem? Well, we turned to Tachi Ono, a Japanese process engineer who taught us a tremendous amount about safety. Muda, the word over there, is the Japanese term for waste. Tachi Ono suggested that there are 6 categories of waste in U.S. healthcare, or in healthcare in general. The first is delay, time spent waiting for something. How much time do patients spend in waiting rooms, in the emergency department, in waiting rooms, in the preoperative space, in waiting rooms throughout healthcare systems around the world? The second category of waste was rework, having to redo a task that wasn't performed properly the first time around. The third category was overproduction, too much medicine, precautionary testing and treatment in order to avoid litigation or because of inaccurate information that was gathered inaccurately the first time. The fourth category was unnecessary movement. In this one, this was not only of patients, but also of information that did not produce or add value. The fifth category was defects. We've already talked a little bit about creating error-free or defect-free medicine. Here, defects, mistakes, errors add cost and waste to a medical system. They add delays in the production of good health. And the final one that he suggested was wasted energy of the workforce. And perhaps the worst source of waste in our system, the wasted energy and will of our patients and families themselves. Built on these principles, IHI built a hospital inpatient waste identification tool. That's a mouthful, but inpatient waste identification tool. This tool works at a ward level and at a unit and at a system level, and goes bed by bed to understand how well that bed is being utilized and whether specific sources of delay and waste are present. Adverse drug events, procedural complications, flow delays, critical care delays, nosocomial infections, all of which contribute to wasted bed days in U.S. hospitals. Using tools like these, health systems like Intermountain Healthcare in Salt Lake City are identifying massive amounts of waste in their system. This study found that up to 50% of time by clinician specialists was wasted in their healthcare system. This amounted to $1.6 million per year per ward in this single healthcare system. Let's move on now to the third category, improving patient flow. Here we start with this image, this painting that I found in the wall of an emergency department in a hospital in Singapore. Here, the designers of this emergency department understand something about the psychology of the waiting patient in the emergency room. What drives patients crazy is not just the waiting, it's the waiting without knowing what to expect next. That's what actually drives people crazy. In one ER, painted on the walls were the expectations of what patients would happen to them next in the A&E. Knowing what to expect, patients were able to modulate their expectations. Or even more accurately, you have systems like this one, which actually quantify your waiting time and tell you exactly when you're expected to move from one place in the system to the next. In that hospital, another hospital in Singapore, they've truly mastered flow. This is Tang Tok Seng Hospital, where bed occupancy has been completely mapped out. On the left of this slide, you see that they've got 1,048, this is a weekly flow, 1,048 patients in, this is what they expect, 1,053 patients out in a typical week. They've got their solution on the wall. You see avenues to avoid admissions if they need them, and outlet valves if they need them to speed up outflow of patients when and if they need those. On the right of the slide, you see radio frequency ID tags. These tags allow their system managers to track patients as they move throughout the hospital and really keep accurate track of the flow in the system. They use that data from those RFID tags to do this. This, to me, when I first saw it, I was really surprised. I thought this was mission control in a space center and an airline industry. But this is in a hospital. This is where they track patients in every clinical unit in their entire hospital. This is mission control at TTSH. And this is what one of those screens looks like. This is a screenshot from one of those panels up there. And each of those numbers represents an individual patient, male or female, and the ones in red suggest patients that are experiencing delays in care that are opportunities for saving wasted time and reducing delays. But optimizing flow isn't just about tracking from one destination to the next in a hospital. This is an orthopedic surgeon, Tony DeGioia at the University of Pittsburgh. He's using new designs to improve patient outcomes from total hip and total knee replacement surgery, using design principles that optimize bed utilization and reduce bed delays. The focus here is on upfront, pre-op planning, pre-op rehab, pre-op discharge planning, and wellness in the orthopedic unit. Here are some images from Tony DeGioia's orthopedics unit. And you can see there, patients are already doing exercise, and they're practicing to be at home on the right and getting ready to transition back to being in their homes. Here are the results from Tony DeGioia's experiments. Mortality at 0.1%, infection rates at 0.3%, 0 dislocations. 98% of these patients get antibiotics within 1 hour of surgery, which is the standard of practice. And it's effective. 91% of patients are discharged without handheld assistance, directly to home, from total hip and total knee replacement surgery. The national rates in the US sit closer to the 30% range, 3 times as effective in Tony DeGioia's orthopedic unit. 99% of patients reported that pain was not an impediment to physical therapy, including same day of surgery physical therapy. This is remarkable. Patients were doing physical therapy and not experiencing pain as a barrier on the day that they had surgery after their operating room experience. So let's move now to the next section here. This is about increasing manpower. I know manpower is a big problem here, very big problem here. We've heard a lot of discussion about it already today. But I want to take you for a minute across the Red Sea to Africa, where I've done some work, and where the health workforce is even more strapped and even more pressed and in much worse shape. Let me share a story from South Africa. South Africa faces a crushing burden of disease, and it's of 2 different varieties. It's both infectious disease in nature and a very significant rising tide of chronic diseases, diabetes, cardiovascular disease, myocardial infarctions, the same kinds of conditions that affect patients here. In 2008, the South African government made an important promise to its citizens that any patient would be able to be served in its hospitals and in its clinics. Clinics faced crushing new burden of patients and simply couldn't cope. Patient care suffered, patients lost confidence in the system and fell out of the system. And worse yet, staff got frustrated, facing these huge loads of patients that are queuing up in front of the clinic, knowing that there's no way that they're going to be able to get through them, knowing that they couldn't see everybody in the ambulatory and emergency departments. They got frustrated. They left the healthcare system. There was high turnover rates and significant burnout. One of the nurses in a clinic in Kailicha, which is a poor area outside of Cape Town in South Africa, a clinic called Ubuntu Clinic, had an idea about how to manage stable patients, and we've heard some of these ideas described earlier today. She suggested that they be managed in chronic care clubs. Why not manage 30 or so patients, stable patients, in a group visit once a month? One nurse could triage and manage all 30 patients in literally 30 minutes, work that would normally have taken 2 nurses the whole day. The clinic could see literally hundreds of patients with the same staffing equivalent that they currently had. And this is what happened next. Within 18 months, the number of clubs in this South African province had gone from 1 to 450. And there are over 12,000 patients that are now being managed through these chronic care clubs. A single nurse can now process up to 100 patients a day when she previously was able to only see around 15. And it worked for patients too. Here are the clinical outcomes after 2 years since the club enrollment. 94.3% of these chronic care patients are still in the same clinic, and only 2.4% have had a negative outcome, either death or loss to follow-up. I'm going to take you now to a different story. Here's another strategy to get more from your manpower. This story comes from Scotland, where they established multidisciplinary teams in the ICU. The teams consisted of nurses, doctors, pharmacy, infection control, clerks, and so on, where everyone was allowed to practice to the top of their license, freeing time and sparing the doctor or nurse from the clerical and non-value-added tasks that they often faced. Healthcare Improvement Scotland, a government agency, used this concept throughout its ICUs and all of the government hospitals in the country, increasing coverage of these multidisciplinary teams from 74% to 93% over a 3-year period. And this is what happened. Not only did it improve satisfaction with their jobs and improve teamwork, but it also improved patient-level outcomes. ICU mortality, it's hard to attribute these results directly to the multidisciplinary teams. There were other things going on at the same time. But it tracked at the same time with dramatic reductions in mortality across all of the country's ICUs. And this, but the most powerful and active set of innovations is in hospital care is in patient-centered design. And we heard a little bit about design thinking earlier today, and I want to take you back to Singapore again for a moment. This is Singapore's KTPH hospital, where the community comes to garden, students come to study, and patients are brought together with nature. This is remarkable, to me it was remarkable to see this kind of hospital in real life. As I walked through the gardens of this lobby, this is the lobby of the KTPH hospital, I thought to myself, if I were a doctor here, it would certainly be a joy to come to work. This is not only patient-centered design, this is actually staff-centered design. They sell, by the way, the fruits and vegetables from those community gardens, not only to the patients, but also to their staff. And here's another example. In this setting, retailers of wheelchairs and other rehab equipment brought in designers from IKEA, the Swedish furniture company. These designers helped them to design displays for rehab equipment, for retail rehab equipment, which patients could use to better compare features. I've never seen this before, comparing features of wheelchairs and pricing on wheelchairs to make appropriate patient-informed decisions about which piece of rehab equipment is the right one for them. And here's another example. Here, this is a room for, I'm going to say this wrong, it's a German word, Kaiserslautern Military Community Medical Center in Germany. They wanted to give every patient a window onto the world. A window because, not just because it's a nice thing to do, but because the data shows that having a window prevents delirium and increases patient mobility. We also know that if the bathroom in a patient room is on the same side as the patient bed, it contributes significantly less patient falls. But at the same time, if a bathroom is in the room between the patient bed and the doorway, it obstructs the nurse's view from the central nursing station of the patient's bed. So where to put the bathroom? That was the challenge. Designers and patients worked together, looking for answers and innovating together. And they found an elegant solution. The room was designed as a parallelogram, which allowed the bathroom to be recessed from view on the patient side of the room and preserve the line of sight from the nursing station to the head of the bed. What about single patient rooms, by the way? They might be patient-centered, but what about the cost? I'm sure you'd ask. The business case seems counterintuitive, but a study that we did found that single rooms increase bed occupancy from 75% to 90 to 95%, and it decreases complications from hospital-acquired infections, naturally, because you don't have patients with that can share nosocomial pathogens. So we modeled this out a bit. We took a 300-bed hospital, which is a medium-sized hospital in the United States, that costs roughly $350 million capital expense to build. To convert those from double rooms to single rooms would cost an extra $30 million on top of that $350 million. But we found when we did the modeling that it saves approximately $10 million per year. And it saves that through decreasing length of stay and increasing bed occupancy. So this pays back the investment in a short 3 years. Or consider this story. And this story combines the features of all the previous stories and principles that I've been describing before. Makes hospitals safer, healthcare settings safer, it reduces waste, it improves flow, it uses the manpower more efficiently, and it designs differently using patient-centered concepts. This patient is named Christian Farman. Christian was a mechanic and an athlete. And in 2004, 2005, he developed end-stage renal disease. And that required, for him, hemodialysis for the first time. Christian had never been a patient with a chronic condition, so this was all new to him. He had led a very active and fulfilling life, and all of a sudden he needed to come to a clinic, be hooked up to a machine for 4 to 5 hours every other day throughout the week, and it completely disrupted his life. He lost his job, he had trouble being himself. He tried to work with the nursing staff there to try to find a different way. And he persuaded a nurse at Ryhoff Hospital in Jönköping County that traditional hemodialysis wasn't going to work for him. And he asked her to teach him how to self-administer his dialysate, and how to clean the equipment, and how to hook himself up to the tubing. Christian learned how to be a self-care provider. And then he started giving himself. He started self-administering his dialysis when he came to the center. And he did it on his own schedule. And then he taught another person. He taught a 73-year-old woman how to do it. And they started to teach other people within their clinic setting how to do it. Soon they had established a new way. And their aim now is to get 75% of patients in this county to self-administer hemodialysis in Jönköping County. And this is what they found from Christian. These are the lessons. I have a new definition of health from Christian. I want to live a full life, I have more energy, and I'm complete. The oldest patient now on self-dialysis, 83 years old, and the care is safer in his hands. And from the nursing staff of this dialysis center, she was surprised at the design differences when patients and families took over care. They're now managing at a half to a third less cost per patient, and there's evidence that they're gathering about better outcomes, lower costs, and far fewer complications and infections. Here's some of the other patients from Christian's story. These are other folks that he's trained to do their own dialysis. They come in, they've now established, because this is now a patient-centered dialysis suite, they've established their own, what do you do for 4 hours, I guess, when you're hooked up to the dialysis machine. They've established exercise equipment, bikes, and so on to keep them busy while they're on the dialysis machines. And here's the update on what's happening there. Costs are half of what they are in other dialysis units in the country. Complications are dramatically reduced, and the avoided care of complications has also been avoided. And here's an interesting detail. These patients, Christian and his colleagues, they aren't measuring their success in patient outcomes and all those sorts of things, healthcare outcomes or whatever. They're measuring their success in the indicator that Christian thought was most important. How many of his colleagues and his friends and his fellow patients are returning to work? So here we go. This is the conclusion. These are the 5 dimensions that I spoke to you about: making hospitals safer, reducing waste in hospitals, improving flow of patients through systems, increasing manpower, and developing patient-centered solutions. There's innovation in these 5 areas in hospitals and health centers from around the world. The future is now, some say. It's for us to discover, to create, and to innovate. Thank you.